Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Hi, everyone. Welcome to this edition of the Chest Journal podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the pleasure of talking about one of the newer papers coming out called Longitudinal Pulmonary Artery Pressure Trajectories Inform Clinical Outcome in Kidney Transplantation Patients. And I'm fortunate to be joined by the first author of that paper, Dr. Katarina Zeder. So Katarina, thanks so much for being here. If you wouldn't mind for a moment, just give us a little more background on who you are and where you work.
Hi. Thank you for the kind invitation to talk about my research today on this podcast series. So my name is Katarina Zeder, and I'm a physician scientist and expert in pulmonary hypertension. I received my medical degree and my translational PhD from the Medical University of Graz in Austria. And in 2024, I joined the faculty at the University of Maryland, School of Medicine, Division of Respiratory Critical Care and Sleep Medicine in Baltimore, and also the University of Maryland Institute for Health Computing in Bethesda, Maryland.
Fantastic. Thank you for that overview, and thanks for joining us today. So we're going to be talking about this paper, in particular some thoughts around pulmonary artery pressures and patients before and after kidney transplantation. So kind of going into this study, talking about the background, what did we know about pulmonary hypertension and end-stage kidney disease or renal transplantation going into this study that you did?
So maybe I'll just start quickly to introduce pulmonary hypertension to the audience, if that's okay. So pulmonary hypertension is a heterogeneous disease, which is defined by an elevation in mean pulmonary pressure more than 20 millimeters of mercury at right heart catheterization. And pH is further hemodynamically classified into pre-capillary pH, which is characterized by pulmonary arterial remodeling, resulting in an increase in pulmonary vascular resistance, and post-capillary pH, which occurs with left heart disease, marked by an increase in pulmonary arterial bed pressure. In kidney failure specifically, pH is a robust, reproducible, and independent predictor of hospitalization and mortality, and also a predictor of graft dysfunction in patients undergoing kidney transplantation. However, the prevalence of pH in kidney failure varies strongly based on kidney failure severity, whether patients undergo hemodialysis or not, and if echocardiography or right heart cath is used to diagnose pH. And between the lung vessels and the kidney, there is a complex interplay and many factors that may ultimately contribute to pH in kidney failure. For example, systematic hypertension and volume overload in kidney failure can lead to left heart failure and left atrial hypertension, which leads to post-capillary pH, or maybe combined pre- and post-capillary pH. Less frequently, we observe pure pre-capillary pH, which is encountered, which then can lead to right heart failure and impaired cardiac output. This in turn worsens kidney failure by venous congestions on the one hand and simultaneous activation of the renin-angiotensin-aldosterone axis on the other hand. And further complicating this very complex interplay is the presence of the arteriovenous fistula for hemodialysis, which can result in high cardiac output from left to right shunt and promote pulmonary hypertension under conditions of high output heart failure. And besides all these factors that I've already mentioned, other comorbidities can also promote pulmonary hypertension, such as anemia, which is frequently observed in kidney failure, or, for example, a comorbid lung disease, which itself promotes pre-capillary pH. And this highlights the role of clinical comorbidities in this population as well.
Thank you for that overview. So this is really a pretty complicated problem, and sounds like much like the rest of the population, patients with end-stage kidney disease can have about any type of pulmonary hypertension, whether it's defined by the hemodynamic class or the WHO group. So a really interesting sort of subpopulation, and you really highlighted a couple things that are really interesting specific to kidney patients with advanced kidney disease, such as the presence of arteriovenous fistulas. So thank you for that. So now that we know kind of what we're up against, first, what inspired the particular study question for this paper?
So pulmonary hypertension in kidney failure is definitely not uncommon, and we encounter these patients quite frequently in the PH clinic, but also in the kidney failure clinic. And we thought that pulmonary hypertension could be a determinant of kidney failure treatment timing, potentially, which includes kidney transplantation. But further data was desperately needed, particularly data on the pulmonary pressure trajectory between pre and post-transplant was lacking. And we also did not know what the prevalence and clinical relevance of pulmonary hypertension post-transplantation is.
Great. So it's kind of a combination of some epidemiologic data that we need to fill in the gaps on, and then also understanding outcomes in this population. So now that we kind of understand the framework and the key questions, can you give us a basic overview of the study design?
Yeah, of course. This was a retrospective study where we used a primary cohort and a validation cohort. We included patients who underwent kidney transplantations who were referred for echocardiography before and after transplantation in the primary cohort. And in the validation cohort, we had both available echocardiography and right heart catheterization at both time points.
Fantastic. So we're going to get some idea, both non-invasive and invasive hemodynamic parameters in this population. And going through the process of designing this study, what were the key takeaways that you found as you proceeded through the analysis?
So I think I can summarize 3 takeaways from this study. The first one is we were surprised to see that pulmonary hypertension post-transplantation was relatively common, affecting almost 50% of the study population when we use a lower echocardiographic threshold to diagnose PH, and almost 10% if choosing a more conservative higher threshold. The second point is when modeling the change in pulmonary arterial pressure from pre to post-transplantation as a continuous variable, we observed a longitudinal mortality risk increase with every single 1 millimeters of mercury increase in pulmonary pressure from pre to post-transplant, which was adjusted for age, sex, and baseline pulmonary pressure. Specifically, we observed a 21% increase in all-cause mortality risk per 10 millimeters of mercury increase in pulmonary pressure, but also we observed a 17% risk reduction of mortality when pulmonary pressure decreased by 10 millimeters of mercury from pre to post-transplantation. And this suggests that the longitudinal change in pulmonary pressure may be an overlooked prognosticator in this population, and that assessment of pulmonary pressure may help risk stratify patients. And the third key takeaway point is we observed that pulmonary hypertension post-transplantation was independently associated with increased risk of mortality, particularly in those patients who developed pulmonary hypertension newly post-transplantation, so patients who did not have pulmonary hypertension before transplantation. Importantly, we also observed a subgroup of patients in whom pulmonary hypertension resolved post-transplantation, and those patients had favorable outcome.
So the really interesting findings, and it's nice to see that it's kind of, proportionally moves in both directions. So things get basically shows that this continuous relationship works in both directions in terms of the effect on the outcomes, which is very interesting. The particular subgroup that I found to be most fascinating here was the patients that developed new pulmonary hypertension after kidney transplant. Do you have any hypotheses why this may be occurring, or as to the etiology of why this may happen after transplant?
So we did observe that patients who had new PH post-transplantation, they had a significant increase in creatinine post-transplantation, which may raise the speculation that pulmonary pressure increase could be a sign of graft dysfunction. In our validation cohort, where we also had right heart cath data, we observed that patients with new PH had an increase in mean pulmonary pressure, but also in pulmonary wedge pressure and right arterial pressure from pre to post kidney transplantation, which is a hemodynamic constellation consistent with volume overload, but also primary left heart dysfunction. A more speculative mechanism could therefore involve cardiotoxicity of immunosuppressive medication that lead to diastolic left ventricular dysfunction, because left ventricular ejection fraction in echocardiography was normal from pre and post kidney transplantation in the cohorts. But of course, these speculations must consider limitations of the study associated with the retrospective studies design and selection bias of the cohort.
Absolutely, yeah. Thank you. And I think another thing that's mentioned in the discussion and kind of tying into what we were talking about earlier is what role does the fistula play in the development of pulmonary hypertension after the fact? That's something else I think would be interesting to look into in the future. Now that we have sort of an idea of what these trajectories look like as a result of the study that you did, both the initial cohort and the validation cohort, what kind of things do you think clinicians should be thinking about when they're taking care of patients pre and post kidney transplant, specifically with regards to pulmonary hypertension? Do you have any ideas about screening or other things that we should be on the lookout for?
So, as mentioned in the beginning, pH before transplantation is already an established risk factor in patients undergoing kidney transplantation, which is associated with increased mortality risk, but also delayed graft function, graft dysfunction, or graft failure post-transplantation. In the US, screening for pulmonary hypertension before transplantation using echocardiography is actually recommended only as part of the pre-transplant cardiac evaluation if time on hemodialysis exceeds 2 years. Although practice patterns are changing towards a routine echocardiographic evaluation of patients as part of the transplantation listing procedures. Based on also the same recommendations, severe pulmonary hypertension, which in these recommendations is vaguely defined as a systolic pulmonary pressure greater than 60 in right heart cath, is even listed as a relative contraindication, presumably due to perioperative risk and precludes some kidney failure patients from receiving a potentially curative treatment. Surprisingly, we observed that in some patients, even severe pH resolved post-transplantation, which was then associated with favorable overall survival. We therefore think that more data on pulmonary pressure thresholds and pulmonary hypertension phenotypes are needed that could potentially be helpful for longitudinal risk stratification of kidney transplantation patients. We also show that pulmonary hypertension post-kidney transplantation is significantly associated with shortened lifespan. And this is actually the first time that this has been shown. And this opens the question of whether it may be useful to screen for pulmonary hypertension in patients pre as well as post-kidney transplantation, and that pulmonary hypertension may potentially serve as a clinical biomarker for prognostication of patients in the post-transplant period, especially when considering the role of pulmonary arterial pressure in the pathophysiology of kidney failure and graft dysfunction. More importantly, these observations that we made in our manuscript are mainly echocardiography based, which is particularly attractive in the clinical setting, since the assessment of systolic pulmonary arterial pressure by echo is a single, simple, and non-invasive measurement with broad availability.
Great. Thank you for that overview. I think you gave us, a lot of us that take care of patients with pulmonary hypertension and renal dysfunction, a lot to think about, how we might approach these patients. And I can think about things that we'd be worried about in the future, that we'll turn to in a couple of questions from now. You alluded to earlier, some limitations of the study, that you'd want readers to be aware of. What other words of caution do you have for the readers in interpreting these results?
So this is, of course, a retrospective study, and in order to analyze longitudinal changes, the patients were subject to referral bias, especially considering the fact that pulmonary pressure is currently not routinely monitored, particularly in the post-transplant period in clinical practice. Also, right heart cath is the gold standard to diagnose pH, but it was not available in the primary cohort. And we did not have detailed information on donor organs, duration of dialysis pre-kidney transplantation, volume status of the patients, and whether the arteriovenous fistula was closed or not post-transplantation.
Great. Thank you for that overview. I think those are some really important things for us to consider. And that really ties in nicely to my next question, which is thinking about future studies. This is a great great study that generated a lot of high quality information for us. If you were going to design a prospective study to answer one or some of the questions that you started to unearth here, what would have been optimal prospective study design look like to you?
So ideally, we want to have a prospective study, which includes systematic and detailed echocardiography measurements in patients before and after kidney transplantation in a very controlled setting. Even more ideal would be the use of right heart cath, but this is obviously ethically not always available. But for the controlled setting, we could use, for example, that all echocardiographies or right heart caths should be performed standardized pre- and post-dialysis to determine volume status, which contributes to pH, and at the same time point, pre- and post-kidney transplantation. And then, of course, information on the arteriovenous shunts, whether they were close or not, and detailed characterizations of the baseline cohort would be ideal.
Absolutely. Yeah, that's the question that's always in my mind as you get these patients through transplant and they have good graft function. What role does that fistula play in the development of problems later? Katarina, thank you so much for spending time with us today. This is a really interesting study, and I'm glad you were able to take us through the high points of it. I encourage everyone to go to the journal itself and read it. Is there anything else that you want to share or any take-home points you have for the audience?
Thank you for inviting me again. I would just like to quickly thank my co-authors for their valuable help in this project, and with special thanks to Dr. Shuman Kundu, who did excellent statistical analysis in this manuscript in this project, and Professor Evan Britton from the Vanderbilt University Nashville, Tennessee, for the excellent collaboration. And of course, my mentor in this project, Professor Bradley Marin, who is also the executive co-director of the Institute for Health Computing of the University of Maryland in Bethesda, Maryland, where I'm currently working.
Fantastic. Thanks again for joining us today, Dr. Zeder. Thanks to all the listeners for tuning in, and we will see you next time.
Thank you.